This week on the BackTable podcast.
You know, there's only two things that you have to do to be a good surgeon, and it's you have to know anatomy, so you have to have the knowledge of anatomy, and you have to have exposure. And if you have one without the other, you are up the proverbial creek. And so, you know, if you know what you need to see, but you can't figure out a way to see it, you can't progress the surgery forward. So in these patients, you know, there's a liver retractor that we use, which is a 5 millimeter long snake-like device that, as you turn it, shapes itself into almost like a curved metal triangle. So it's got a big space in the center of it. So we can kind of put that underneath the uterus and scoop it up a little bit and still only have a small surface area that's in contact with the uterus. So we'll use that liver retractor.
All right, welcome back to another episode of BackTable OBGYN. This is Mark Hoffman, your host, and I've got with me a good friend, as we often have on our show, Dr. Craig Sobolewski. Welcome to the show.
Yeah, it's great to be here. I really appreciate the invitation, Mark.
It's always a pleasure to get to catch up with you. You're a friend and mentor and someone I always, even though we have a lot of fun and hang out, I always feel like I learn stuff whenever we get to see each other. And so for our listeners, Dr. Sobolewski is a minimally invasive GYN surgeon at Duke. We still are friends. Kentucky beat Duke this year, so it makes it a little easier for me. But I think you guys have a better team.
We'll throw some crumbs every now and again, you know.
Gotta give us hope to come back the next time. Assistant professor of OBGYN and chief of the Division of Minimally Invasive GYN Surgery and the Department of OBGYN at Duke. Is that correct?
Yep, for almost 25 years now. 24 years, I guess. Yeah.
Yeah, right. You were the first MIG surgeon there, right? Came from Pennsylvania.
Yeah, you know, I was. I'm old, Mark, so I did not do a fellowship, although there were a few of those sort of unaccredited 1-year things. But I trained in the shadows of Harry Rich. So I was up in Allentown, Pennsylvania, which is about an hour outside of Scranton, where Harry was, and a bunch of my attendings and faculty and mentors knew him personally. He would let anybody who wanted to come into the OR with him. And
is that what his practice was?
Yeah, it was. Yeah, private practice up in Scranton, PA, and Wilkes-Barre, Scranton area. The faculty, Larry Glazerman, Mike Patriarcho at my institution, got the itch and were, early adopters, and we were a small program and a ton of surgical experience. These were the days where industry was very interested in helping to facilitate the adoption, and there were some training facilities that we used to get to go to 1 or 2 times every year and do pig labs, cadaver labs, that sort of thing. And so grew up kind of making stuff up as we went along, and grandfathered in, which, I used to say now that I'm a grandfather, I guess I really am a grandfathered in, but
I know it's an audio podcast, but you look good for a grandpa. Let me just say that. You're
pop-pop. I'm a pop-pop.
Yeah, my dad's a pop-pop. That's great. It's a fun time. I hear, all the happiness curves. I do a lot of stuff on wellness and those kinds of things. It's like people in 20s, and then it goes down when you have kids. But like the happiest people on planet Earth are the grandparents.
I highly recommend it. Yep.
Yeah, good. It's good to get some anecdotal evidence to go with the the clinical evidence we see. But so you gave us a little bit of a background, and that's what we like to start our shows with, let our listeners kind of learn about how you are. And then you went to Duke 25 years ago. They just picked up the phone and said, hey, we need somebody, or what was the story there?
Yeah, so I was a residency program director for several years at Lehigh, and, realized early on that we needed to figure out ways to do laparoscopic training in safe ways that were motivational and fun. And so created a lot of low fidelity hands-on training exercises that would culminate at the end of the year in a laparoscopic Olympics, where each class would compete against each other, full on opening ceremony, the whole shebang, crowning of the victors at the end, that sort of thing. And, I used to take my kids' toys. Like I distinctly remember taking like a Hercules figure or something, and they had to suture his leg down, and it was the Lilliputian ligature was the name of the exercise, and stuff like that. But then some of the things we did, we actually monitored and did some pretty simple studies of intervention versus no intervention, and then presented a lot of it at CREOG-APCO. And my chair, Haywood Brown, here at Duke, when he came here, realized that there was a need, and he knew me through through the program directorship because he was a program director before he came here. And that's how I got the phone call.
So how long, because John Stiggy was at Duke, right? Initially, before he went over to
John was
UNC?
here before I got here. John was here. Who else was here? Arthur Haney was here.
He was my chair at the University of Chicago.
Yeah. I kind of knew
he
that
retired
you were there.
as chair and then became chair. So he was collecting 2 paychecks, I think.
Yeah. He was leaving just as I was coming.
I think your chair was my chair when I interviewed for residency there. I remember I had a really good meeting with him. He's a really amazing guy. Haywood, really interesting guy. Well, good. No, and you work with a couple of good friends too, especially, Arlene, who trained me, is someone who I always like to give credit to whenever I have a chance, and she's one of the best. So you've got a good group down there, lucky fellows.
Yeah, new fellowship. Yeah, so Arlene Song is here, and Amy Broach from University of Pittsburgh. This is just our second year.
So do you have a first and second year fellow, or are you just doing one every other?
We started with one, and then we just matched our first fellow. So our first fellow was an internal candidate outside of the match, and then we matched what we think is going to be a great fellow for next year. And then after this year, we'll have one every year.
It's great. It's a lot of work. I mean, you mentioned the 1-year apprentices. Even when I was applying 15 years ago, there were 20, I think, programs, and 10 were 1 year.
It's remarkable what's happened, yeah.
As you know, my career kind of took a little bit of a left turn, but it was sort of the time I was like, well, I should, we have a partner now, and we have enough of us doing this. We could probably think about a fellowship. But the requirements now to get a fellowship, before it was like, who wants to come work with me? Now, it really is. It's a rigorous application process, and you and many others have done a ton of work to really build it up. And it was like, oh man, all this stuff I got to do to have a fellowship. And then I, got to apply for my current position, and that blew that candle out for at least the time being. So it is a lot of work, and it's a great program. You guys have an awesome group of faculty for sure.
Yeah, I feel very blessed for sure. And I know your institution feels blessed to have you in your new role there. So.
They are extremely lucky, for sure.
They are. Absolutely.
It's a fun time to be a part of it. There's a lot happening where we are, so I'm excited. But, I know we had Jamal on recently talking a little bit about robotics specifically in pregnancy, but you had given a talk at AGL, and I was really excited to have you come chat with us about laparoscopy in pregnant patients and physiologic differences and those kinds of things. I wanted to hear a little bit about sort of how you got interested in that and where all that came out of.
Well, yeah, thanks. I think it's something that we all needed to, at some point in our careers, whether we're a generalist or a specialist or subspecialist, have some experience with and have to think about. What's really been interesting over a long career is, what at one point was pretty avant-garde is now considered routine, and that's just the evolution of life and certainly the evolution of medicine. And so I think that we really used to have to be very thoughtful about who were appropriate patients to consider this approach in and who were not. And interestingly, when I came here in the early 2000s, general surgeon Steve Eubanks was the division director for the MIS portion of the general surgery department here at Duke. And if you kind of look at publications on the effects of pneumoperitoneum on pregnant fetuses, he did a lot of that work. So here at Duke, there's a big vivarium. He did pregnant ewes, so pregnant sheep studies, looking at the effects of pneumoperitoneum and safety. And so a lot of the groundbreaking research was, laparotomy on a pregnant sheep, invasive monitoring of both mother and fetus, close the sheep back up, do pneumoperitoneum for an hour, monitor PO2, PCO2, uterine blood flow, those kinds of things. And, thankfully to pioneers like him and others, we've learned a lot, and we know that done properly, it's incredibly safe. And all of the standard advantages of laparoscopy that we talk to all of our patients about certainly pertain to pregnant patients, and in many ways, are even more important, like, lower risk for VTE, for example, things like that. So yeah, so it was pretty interesting to hear, meet him and hear about the work that he was doing when I first got here. And
it's incredible to think about being a physician and scientist like that. I mean, again, I know there's a lot of folks doing research out there, but so much about academic medicine these days, in many places, it's productivity. It's really, you have to decide clinical practice or focus on research. There's just, you have to, it's only so many hours in the day. And to think about some of these guys that we're doing, I'm sure he was a busy surgeon, and then in his spare time operating on sheep. It just seems, yeah, it is. It is an amazing testament to the guys who were able to do these things, so long ago. It wasn't that long ago, I guess, that allowed us to do these things that you said. Like you said, we take it for granted. Oh yeah, well, obviously laparoscopy is the right thing to do in these situations. But there were times, I talked to Arnie about this, I heard all the stories in Michigan, and it was like, malpractice, we're calling peer review if you consider doing these crazy things. And it's like, to be a pioneer, I mean, it takes guts.
Yeah, definitely need some cowboys out there for sure. So he did that. And, I think at first I was like, well, gosh, you're a general surgeon. Why are you interested in this? And the reality is the overwhelming majority of abdominal surgeries on pregnant patients are done for non-gynecologic indications. The majority of them are acute appendicitis or acute cholecystitis. And so in retrospect, it made perfect sense that he was interested in doing that research at that time, but seemed a little bit unusual for a non-gynecologic, non-OBGYN to be doing a lot of that work.
No, it's important work though. That's right. I mean, we think about, I haven't done done many surgeries on pregnant patients, right? So there's a few things we can get into in a little bit, but like as a resident managing pregnant patients who ultimately had surgical issues, there was almost never a gynecologic indication per se.
Yeah.
So what are the most common surgeries? I mean, you mentioned appendicitis, cholecystitis. Like, talk to us about, I don't know what I don't know if that's part of your talk or not, but like thinking about how those present in patients that are pregnant and how differently they present. I mean, I know it can be a little trickier.
It wasn't much of it. It really wasn't part of the focus of the presentation. But I think that, the classic, and we should all know this as obstetricians, the classic teaching about appendicitis and pregnancy is that the location of the appendix obviously changes with the gravid uterus. And so the classic signs may not all be obvious. So, you might not have pain in McBurney's point. You might not have a positive psoas sign if depending on the gestational age of the patient. So, abdominal pain, white count, think appendicitis.
I remember. No, I know that. I remember the patient from residency that we kind of watched, and was like, don't want to watch too long, but yeah, it definitely looks a little different. So,
well, it's interesting now because since COVID, they don't do that many appendectomies anymore. They all just get antibiotics and watched, or not all of them, obviously, but so many more than what I remember to be the case.
No, they medically manage a lot of them. And I feel like maybe the pendulum's starting to swing back a little bit because there's some they watch and maybe it doesn't go great. And it's like, if it ruptures, like it's a lot worse than
you would think, wouldn't you?
Yeah. And so I think this is anecdotal from what I'm seeing, but it seems like maybe the pendulum's swinging the other way, but that's always how it works.
Right.
So talk about kind of the most common GYN indications. Like, why are we operating on pregnant patients?
I mean, the obvious, well, perhaps not obvious, but the most common indications from a gynecologic perspective are going to be symptomatic ovarian cysts and torsion. So most other gynecologic indications for at least elective surgical intervention are things that we would typically watch during pregnancy. So fibroids, endometriosis, the kinds of common benign surgically treated gynecologic entities are not something that we're going to deal with during pregnancy and can safely wait until afterwards. But symptomatic cysts, and the key word there should be symptomatic. And then if there's any concern about torsion.
Talk to me about symptomatic cysts. Like, I mean, I think a lot of times we see them and they're like, okay, they're there, but what are ones besides torsion that would make you consider surgery?
Yeah, I think it would need to be a hard push. Patient is really significantly disabled by pain and discomfort. The cyst that's incidentally noted at the time of a dating ultrasound or that sort of thing should not be operated on. It might be appropriate to follow it, and if it's enlarging and still asymptomatic and has otherwise benign features, I think those are the ones that you sit on unless there's substantial worsening of the patient's quality of life. The classic, it still surprises me, but the classic data and teaching is that 5% of these could be malignant, which just seems so shocking to me. That seems like such a high number.
5% of all cysts in pregnancy?
Yeah.
Or just in general?
Adnexal cysts in pregnancy.
What makes them different in pregnancy? Because, I mean, we think about, simple cysts, are we including those or complex, or is it just all comers?
I can't answer the question, Mark. I think it's likely a combination of the fact that they are persistent as opposed, so if you just look at the denominator, So, so the denominators are going to be substantially different, right? All of the women who are not pregnant versus a subset of women who are. And of all of the cysts in non-pregnant patients, the majority of them are going to be functional or physiologic and go away. And so of those in pregnancy that persist over a smaller diameter, I think it just changes the percentage.
Most cysts that we're seeing in non-pregnant patients are related to the cycle, ovulatory, hemorrhagic cysts. All those things are things that result from
Biology.
Processes that are we see in non-pregnant cyclic patients. So that's interesting.
Yeah.
No, I like that. Okay, so
it's just
sort of
conjecture,
eliminating. Yeah. Hey, listen.
I think it makes sense to me.
It's where research comes from. Oh yeah, I've solved a million problems in my brain. Don't worry. we don't need research.
That's right.
But it makes sense. I mean, it's got a pathologic or a physiologic kind of plausible pathway. There's certain things we just don't know, but that makes sense.
Yeah. But so those are the biggest gynecologic. Although nowadays, as a laparoscopic surgeon, and I know there's a lot of presentations about this over the more recent years at meetings like AAGL, our laparoscopically performed abdominal cerclage in pregnant and non-pregnant patients, but in pregnant patients too. So,
are you doing a bunch of those?
I don't know. Define a bunch. We do
more than zero.
Yes, more than zero is for sure. Yeah, we have a prematurity prevention center here at Duke, and so patients from the surrounding catchment area come to us, and one of the more common reasons that they're seen here in that clinic, there's a variety of things obviously, but one of them is cervical incompetence, and so ideally those patients are seen in clinic when they're not pregnant, and then they get a nice, easy, simple laparoscopic abdominal cerclage if they've failed a previous vaginal attempt.
Well, that was Kat Payne's big thing. I don't know, I guess it was if he was doing those at Duke or not, but when he was at the University of Chicago, that was his, he lined them up. That's all he really did. He would do them. I mean, we've talked about this on the show a number of times, but the beautiful mini laparotomy he would do. I mean, God, it was like 2 centimeters. And you'd see these incisions. You're like, there's no way.
That's fascinating.
We're doing, and he would do no bladder flap. We'd put a figure of 8 in the fundus of the uterus, pull it up, and use, he'd have the blunt needle. He'd always scare a medical student, and
on the Merceline tape, blunt
Merceline
needle
tape,
and
tied down the knot with silk stitches, but it was get in, get out. All we weren't throwing the cerclage stitch, but we were getting in, getting out with the mini lap, and it became like one of the most valuable incisions now that especially with more sedation, love a good mini lap. But yeah, that was something that I think he had developed at Duke, and when he came to Chicago, that was like the big thing he did there. So I wasn't sure if there was any sort of a carryover, people he'd trained, or if he took it with him or what.
Yeah, not that he trained, but Haywood Brown did abdominal cerclages. Dr. Brown is a maternal fetal medicine, and he was the abdominal cerclage person. In fact, we do all of our cerclages standard laparoscopic straight stick, but the very first one that I did robotically, and Dr. Brown came into the OR.
That's pretty cool.
And sat in there and was just harassing me the entire time while I was doing the procedure. That's probably why I don't do them robotically anymore. I just have PTSD from that experience.
So do you do a bladder flap or anything, or just feed it behind the uterines and tie it down?
Yeah, Amy Broach really has sort of spearheaded this in our division, and she has developed this pretty slick technique. So I suspect that we do some things probably uniquely different than some other places. One is that we use just the cup, a colpotomizer cup. So we just use the cup to delineate the apical vagina, the vaginal fornix. So we take some ring forceps, put them on a colpotomy ring, the 4 centimeter one, the large one, and we just have somebody down below just pushing up on the vaginal apex. And it really helps to make sure that we're putting the stitch at the true internal os instead of just guessing.
Oh, that's great.
Yeah.
I use a curved Haney needle driver on the cup. Gives you a little bit of an angle to kind of push up. So, but yeah, same idea when I'm doing like a tricholectomy or something where they don't have a manipulator attached. But yeah, that's a great technique.
Yeah, so we do that for those cerclages. And then she developed a technique where we actually make a fenestration in both the posterior and anterior leaf of the broad ligament. And we put our needle driver below the round through that space to throw our stitches from posterior to anterior. And the angle that you get from that is so nice. It's so perfectly aligned. we do it for all of them, but especially for the pregnant uterus, where sometimes trying to see that space or feel comfortable that you're putting your suture in the appropriate position, not having the visualization that you can get because you can't see there because the broad is intact. So it's a little tricky, I think, probably to envision what
so
we're talking about.
You make a window in the broad so you can see through it?
Uh-huh.
Do you close it back up?
Yeah, we do.
Yeah.
We do. Just a barb suture. And we do make a bladder flap, and, we tie the knot down anteriorly. We don't suture it down like I used to back in the day, or like you said that the Dr. Haney did. But, every time we throw the stitch, Amy always jokes that she gets another gray hair because it is, in those pregnant patients, it is still, so, you got to kind of hold your breath when you're doing it. But
Dr. Haney, I've never seen a man sweat like I saw somebody sweat when he would do those cases in the pregnant patients. He's like, turn the heat down. He was like, I'm not sure it was a sterile field, the amount of sweating he was doing. But no, those were the toughest ones for sure. We weren't doing those through mini laps. This is definitely a bigger incision for those cases, and that's ones where I think, going back to you're talking operating on pregnant patients, that's the ones where I think laparoscopy would provide a massive benefit compared to open. I mean, you're really seeing things in ways you just couldn't before.
No question. Yeah, I couldn't agree more. Yeah. So, those are things, and we can, if you'd like to kind of, get back to the physiology piece of things, because, ideally, there is definitely a sweet spot when you're thinking about doing these operations in pregnancy. That early second trimester is really ideal because, it's scary to be touching the uterus that you can imagine something's kicking back at you when you're in there. And so part of the, what's important to remember about the gravid uterus is that as it gets bigger in the supine position, it's going to cause venous compression on the vena cava. And so, one of the things that we do in that case and others is, routinely we'll tilt the table in a left lateral position. So we'll have anesthesia airplane the table.
Certain number of degrees, or just kind of like enough?
Yes, 11 degrees. No, just enough.
Well, now that everybody's iPhones
can do that.
Is a level, you can tell exactly how much.
Yeah, just enough. And it's as a former obstetrician many years ago, it was always tilt them to the left, right? You ought to put a pillow under them so that they're tilted to the left, and because it gets the uterus a little bit more easily off of the vena cava. But the same thing happens if you tilt them to the right. So if we're putting the suture in on the right side of the patient, we'll tilt the patient to her left. If we're doing it on the other side, then we airplane the table the other way. So whatever you can do, because the residents hear me say this all the time. There's only two things that you have to do to be a good surgeon, and it's you have to know now anatomy. So you have to have the knowledge of anatomy, and you have to have exposure. And if you have one without the other, you are up the proverbial creek. And so, if you know what you need to see, but you can't figure out a way to see it, you can't progress the surgery forward. So in these patients, there's a liver retractor that we use, which is a 5 millimeter long snake-like device that as you turn it, it shapes itself into almost like a curved metal triangle. So it's got a big space in the center of it. So we can kind of put that underneath the uterus and scoop it up a little bit and still only have a small surface area that's in contact with the uterus. So we'll use that liver retractor.
Are you doing that for mostly cerclages?
Yeah. But I would use it if I had a big dermoid or something and it was stuck down there posteriorly and I was trying to get it elevated up out of the pelvis and I couldn't. That'd be the first instrument I'd call for to nudge that uterus over a little bit just to create a little bit more room or space if I had to.
Are they disposable, or I guess
no, it's reusable. Right? Yeah.
Is it?
Yeah, it's reusable. 5 millimeter liver retractor. I suspect they're in every OR.
Oh, very cool.
Yeah. So there are those sort of hemodynamic changes that are important to at least think about.
Does the T-Berg help with the venous congestion? I mean, gravity maybe giving you a little bit of a lift, or how does the Trendelenburg impact physiology in pregnant patients?
Most of the effects of Trendelenburg are net negative, and it's on pulmonary function. So it's going to decrease the compliance, the respiratory compliance, decrease functional residual capacity, decrease overall pulmonary dead space. Just pregnancy itself, the diaphragm raises but by the end of gestation, the diaphragm will elevate by about 4 centimeters. And so already there's less volume available in the chest, and that's just in the standard resting position. And then once you put them in Trendelenburg, now you've got a pressurized abdomen in T-Berg, and that's gonna further affect pulmonary compliance. And yeah,
I'm having Creog flashbacks here. Yeah, no, that's right. All these things I knew once when I was, providing obstetric care.
Yeah. Well,
oh, that's interesting.
Yeah. I mean, physiology of pregnancy is really fascinating because, the way that the body has to compensate for all of these things is really pretty interesting. Like the rib cage gets bigger, even though the diaphragm goes up, the rib cage gets bigger. So your tidal volumes will go up. But because these other pulmonary functions decrease, patients will respond. Essentially, you get a respiratory alkalosis because of the physiology of pregnancy. And so the way that the pregnant patient compensates for that is by increased minute ventilation. So
right.
I know you're a father. I know that you had a wife who's been pregnant, and by the end of their pregnancy, their minute ventilation is up there, man. They're huffing and puffing just so that they don't get too alkalotic.
No, it's an incredible, it is. And I think, a lot of us GYN surgeons, what's unique about us as surgeons, we didn't just train as surgeons, right? We trained as obstetricians as well. And it's one of those things, and most of residency is OB for a lot of us. And so sort of giving it up was something that you probably gave it up after a longer period of time than me. But I do remember it's like, I just want, GYN only job. And then I did OB for a few years. And I remember my chair saying, I think it's time for you to stop doing OB. And I was like, oh man, like it felt like a bit of a loss, honestly.
Yeah, maybe.
At the time, I got over it pretty quick. Well, that's interesting. No, and those are the kinds of things I would imagine that make you want to be a little bit more efficient in the OR, right? Having a plan, all those things. These are not great positions for pregnant patients to be in.
Yeah, the work honestly falls all on our anesthesia colleagues, because they're the ones that have to understand that physiology and make the appropriate changes in the vent settings in order to compensate for that. And so the pulmonary function part, we need to be good colleagues and make sure that we're operating on the lowest, so no more than 15 millimeters of mercury, right? So if you can see as well as you need to at 12, that's probably going to make our anesthesia friends a little nicer when you're having a cup of coffee at the end of the case.
Are you actively trying to minimize the pressure, or is it only if they're complaining across the drape?
So we'll start at 15 to get in. And so it just depends. It depends on, so first of all, any entry technique that you're comfortable using is safe in pregnancy. You clearly need to understand that you might need to think of an alternate site. If you normally go in with ovaries at the umbo, you might want to reconsider that if your patient's 16 weeks pregnant or something like that. But they've all been described in the literature. They've all been demonstrated to be safe. So whether it's varies followed by a trocar, whether it's optical trocar without a varies, whether it's open Hassan, they're all perfectly safe. So
what's your technique?
So we'll universally go in left upper quadrant at Palmer's point. And I typically go in varies up there followed by an optical trocar, but I don't know, depending on my mood, sometimes I'll just go direct optical. And then, we'll get in at 15 just to do our initial survey, and then we'll decrease it a bit. And if we can still see sufficiently well, then we just stay there. I will say that for our pregnant cerclages, we almost always just keep it at 15 just because the view is already so obscured by the size of the uterus, because they're never early second trimester. They're always right around 14, 15 weeks. And that's a challenge. But yeah, I think it's not a bad idea to try to operate on, if your standard is 15, if you can get by with a little bit lower, that's probably in your patient's best interest and certainly makes life a little bit easier for anesthesia.
So what are most of what you're operating on? Is it typically torsion, or is it more big cysts, or is it sort of a combo?
No, honestly, the majority of them are abdominal cerclages. If it's a torsion, it's likely going to be whoever's on call for us at Duke, right? If it's an emergent situation, our faculty, whatever the subspecialty, typically can handle that. Now, if it's something particularly unique about the patient, we may get called in, but most of the time, those are just going to be handled by, whichever provider's on call at that particular site. If it's a little bit more elective, so, worsening pain, dermoid, not torsed, then those patients will get referred to us and we'll take care of them expeditiously, but not emergently.
cystectomies with torsion or not when you're dealing with torsion?
I think as best we can, we should manage these patients in the way that's most appropriate, whether they're pregnant or not. And so if we can safely perform a cystectomy, then I think that we should do that. I think that's just good medical care and good advice generally. I don't think I would criticize somebody who, if it was a generalist and they were nervous and they didn't feel super comfortable and they decided to do an oophorectomy for a torsion, I think that that's fine. But I think in general, just because they're pregnant, we should not take shortcuts if we can avoid it.
Yeah. Talk to me about energy in pregnant patients. Do you think much about that? Does it matter, or is it?
It doesn't matter. I don't think it should matter. I think, you have to be careful to understand, things like direct coupling and ways that, if I like to operate in the near field, so I like to have my laparoscope pretty close to whatever it is that I'm operating on. And, I think you just see better detail. But, if you are doing that and you forget that there's a big, huge uterus behind the tip of the laparoscope that you can't see, and you've got an energy instrument in there, and if it's laying on the uterus or something, and God forbid it, I just feel like if you're going to use some energy, make sure you understand, as is always appropriate, what's nearby. But now you're going to have this big old mass there in the middle that you really don't want to burn if you can avoid it. So,
but no reason to avoid monopolar, no reason to avoid anything. You're not specifically using harmonic or whatever. It's all good surgical technique.
Yeah,
avoiding touching things you don't want to touch.
If I think, when I think about it, what's different about operating in a pregnant patient compared to a non-pregnant patient, I think there are some things that when you are making the decision to operate, and whether any day of the week, you're in your clinic and you see a patient and you're making a decision to operate. Now you've made that decision, then you go through your list of what you do to plan for that procedure. And all that's going to be the same in a pregnant patient, but there's going to be some things that might be a little bit different, right? So pregnancy is a hypercoagulable state. Do I need to do anything differently about my VTE prophylaxis? The answer is no. It really isn't. Even though there are changes, there are physiologic changes in terms of the coagulable factors, most of the increased VTE risk comes from venous. And so I think being efficient in the OR, SCDs, if you have a scoring system that you use to determine VTE risk, and that person scores at a level that would require perioperative heparin is safe in a pregnant patient. So whatever your VTE management is, it shouldn't change based on a pregnant patient. So you're going through your order list. Do you have to prophylax them against infection differently? The answer there is no. So you use standard guidelines for whatever antibiotic prophylaxis based on the procedure that you're doing. When they're in the hospital in pre-op, there are some things you might do differently. So at least we do. So if it's a pre-viable pregnancy, we'll get fetal hearts by Doppler, and that's it. And we'll do that both pre and post procedure. We don't do anything for tocolysis. There's no evidence to support routine tocolytics in any manner. If it's a viable pregnancy, they should have both electronic fetal heart monitoring as well as monitoring for contractions, both pre and post procedure. So that's different, right? That's not going to be in your ERAS order set for whatever procedure you're doing. I don't, think about your trocar entry or your site of entry, how you're going to get in. Think about how you're going to position the patient throughout the operation. Make sure you have an anesthesiologist who's comfortable managing a patient during pregnancy. Postoperatively, other than fetal hearts based on gestational age, whichever way you're going to do it, there's really no guidelines or need to manage those patients differently in the immediate postoperative time frame.
Are you keeping them overnight? You sending them home?
Yep, sending them home. For our cerclages, and there's no evidence to support this necessarily, but for our cerclages, we just document the deepest amniotic fluid pocket in pre-op and post-op. So we do just a quick bedside ultrasound, look at fluid, and then we do a quick bedside ultrasound and look at fluid afterwards, just because we're putting a needle that sometimes goes into the stroma of the uterus, just to document that we didn't rupture them, so that if 3 or 4 days later, God forbid, they rupture,
You know that they ruptured 3 or 4 days later, not.
We know that it didn't happen as a consequence of the procedure that we did, yeah.
Cerclage loose enough that you can do a DNC.
Yeah, that's
afterwards. That was something that we talked about.
I mean, I don't know how you ensure that that's the case. Part of our consent is that the patient might need a hysterotomy for an IUFD. So, ideally it would be nice if you could do that. But the flip side of this is, what's the purpose of the procedure? The purpose of the procedure is to retain the pregnancy. And so I haven't figured out a way to gauge the degree of constriction at the cervix. And so it's all done by eye and gestalt mostly. I will say it's part of the reason that we like doing these standard laparoscopic is just because you can kind of get a little bit better tactile appreciation of how tight you're tying the knot. Although when I do robotics, I swear I can feel what I'm doing. But
no, your brain plays funny tricks on you for sure. I mean, it does seem like you can feel it.
Yeah.
But when you're doing these on non-pregnant patients, are you making them a little looser, or just again sort of just like feel and see? And
well, on the non-pregnant patient, you have a manipulator in, so you know that you can that your cervix is at least dilated to the degree that your manipulator's there. Now that's probably
like a 7 or 8.
7 or 8, yeah. So at least the first trimester miscarriages you can manage that way for sure. But
so how do you counsel patients on who needs a cerclage? I think, again, going back to all the times I heard Kat Paney talk about it, was how many second trimester losses should somebody have to go through? And to him, it was 1. And now that was a pretty controversial take at the time. I'm not as up to date on the conversation, which is why we get you on. But how do you counsel patients? Second trimester losses are traumatic. They're terrible. They're tough.
I will get my good friend and colleague, Dr. Wheeler, who runs the prematurity clinic, to come on and answer that question for you. Because the simple answer is, when they tell us to do it, we do it. We're not involved with that counseling. When we see these patients, the decision's already been made. And then, our counseling is about risks, right? So I know that they've told you this is what you need, but, this is the potential consequences of you having this operation. I want you to understand, the potential.
And they're a MFM?
Yeah.
Interesting.
Yeah. I think that the overwhelming majority, I without kind of reviewing our data, swear by this, but the overwhelming majority of patients have had at least one vaginal cerclage that failed before.
Oh, wow. Okay.
Yeah. So
why is that? And again, I'm not up to date on what's out there. I mean, 10 years ago, last time I looked at it, they just weren't great vaginal cerclages. And honestly, around here, that's kind of all they do. It's not anything that, to your point, it's an MFM driven program at times, or maybe REI. We don't have an REI group here. You got to have a pretty significant volume of patients who need those. And I've never done one in my practice. It's not that anyone's asked me and I said I couldn't. It's not come through our OB programs at all.
Yeah. I mean, I think that, I think it's a factor of, at least my sense is that it's a factor of the fact that abdominal cerclages, the other terminology that was used to describe that procedure was a rescue cerclage, right? So typically abdominal cerclages were, because they were laparotomies, were reserved for patients in whom all other options had been tried and failed and exhausted. So it was truly a rescue operation, because it was such a potentially morbid procedure.
But these days, laparoscopically, I mean, I know you said you guys do a bladder flap. I've seen 50 of them in residency, and not one of them involved a bladder flap. And the numbers from his cases were pretty impressive. I know there's a lot of different ways to do that procedure, but I would say a lot of the ones I see are arguably less morbid than a vaginal cerclage.
No, I think so too. Well, I don't know if less morbid, but maybe not necessarily more morbid.
Not more,
since we can do them minimally invasively. Again, I'm not involved with the counseling, so I don't. I wish I had a better answer for you, Mark. I think, and again, it's Amy does the majority. Amy does all of the non-pregnant cerclages now. In fact, so that's sort of her. Like it or not, that's sort of the way that she's settled into things here. And so I can't answer with certainty, but when we first started doing these, my sense was that these were still patients that had a loss after. The majority of them were referred because whoever their OB was, they had in a previous pregnancy put in a vaginal cerclage and they failed it, and so then now they're pregnant again. They get sent for an MFM consult, and those are the patients that came to us because they had tried and failed a simpler procedure. But that may not be the case anymore. But now that we've got an established program here, maybe the MFM folks are seeing patients and it's just they've had a second trimester loss, and we are just getting them because they had a second trimester loss. I don't know that the answer to that.
I mean, I can see it both ways, and I think the success rate for abdominal cerclage historically is, in terms of maintaining pregnancy till term, is phenomenal. It's one of the most successful procedures that we do, right?
Yeah, I really feel like that we are on the right path of making vaginal cerclage as a thing of the past. I just not familiar enough with what the obstetric algorithm is to decide to answer your question. I think, to Cap Haney's point, I think that if you had one second trimester loss and there was no other explainable reason for it, why not? I will say what it does do is confines all those patients to a C-section. And
yeah, and I think if that's the worst outcome, and obviously there are other complications associated with it, but I think the possibility of a second was something that he talked about it in terms of insurance companies. How many preterm deliveries, 23 weeks, NICU cost does it take to pay for, 15 cerclage, like 20 cerclages for one, is far less than one long NICU stay, 6-month NICU stay. And so those are the kinds of things that, it's not all just about money, but in terms of justifying it, I think, having a success rate that high in something, knowing that what you went through is so traumatic is not something that I think a lot of people would agree to that. And I know that Dr. Haney's cases were coming from all over the country, all over the world. It was in the early days of like message boards and stuff. And it was, we have some friends who sort of become internet famous through their medical procedures. And he was one that I think very early on, like people found him and it was just like, they all just flocked to him and he did all sorts. And we were doing, 3 to 5 on this OR day one, like every week for, year round. Are you, how many you think you do in a month or do you in a year? You said most of yours are pregnant when you get
No, most of ours are non-pregnant. I'd say probably 25% of them are pregnant. And,
it's a lot.
But I bet you we just do a dozen a year, maybe.
Oh, total. Okay.
So, yeah.
And that's part of it too, is like, if we start it and we're going to do 1 or 2 a year, people nearby doing a handful, is that better for them? Probably. I mean, I'm not big on dabbling in general in surgery. And I know we talk about that quite a bit here just in general, but trying to find something that's really rare to do a lot is a challenge.
Yeah, I mean, the non-pregnant ones, Mark, are not difficult for a skilled surgeon like yourself, and you wish that that's all that you got. And those numbers, like I said, probably at least 3/4 of the ones that we do are in the non-pregnant patients. And I think that if the pendulum is swinging to a point where that is the new standard of care treatment, which, like you said, probably ought to be, then there'll be a real need for people to be able to do those, even though second trimester losses hopefully are not that frequent. But that would be the ideal scenario. Yeah,
I mean, it's something that our residents will go their whole residency program not seeing it, and there's other places where it's done a lot. But it's one of those things that, it's important to have your options. But it's a good partnership with MFM and with MIGS, and it's a surgery that I think it's got its place in our work for sure. So what are you using Merceline? What's the suture you're using for?
Yeah, good old Merceline. Yeah, I don't know what else it's used for. What else is that stuff used for? Anything else? I don't know.
Two-sided needle, or the needle at each end, or what?
Yeah.
What's the?
Yeah. So we have a 5 in each of the lower quadrants, a 5 left.
Poor placement. That was my next question.
Yeah, 5, a 5 on the right and the left, a 5 in the left upper quadrant, and a 10 or a 12 at the umbo, and that's just big enough to force that ginormous Merceline needle through there. Sometimes we have to bend it open just a little bit.
You could, I guess you could backload it too, right?
You could.
So
you could.
I do that for my cuff closures for my, CT1 to keep my all fives.
We just bring it up through the vagina.
Yeah.
Yeah. Then we just straighten it and bring it out. But yeah, it'll fit through there. And like I said, we go posterior to anterior on both sides, cut the needle off, straighten it, pull it up through the 5 and tie it down anteriorly.
Closing fascia on a umbilicus in a pregnant patient. How are you doing that?
However you want to.
So are you using Carter Thomason, like a pass-through needle, just with the uterus being right there, just throwing?
Yeah, if it was me, I would, depending on where how close to the uterus is, I don't think I would feel super comfortable doing it that way. So Amy is a product of McGee, and so at the umbo, she's always a open Hassan person. So our trocar there is the fascia's already been tagged at that site. But that's a good question. I don't. If you're going to do something like that, you better keep your eyes wide open and be careful if you're going to use a Carter Thompson or some other suture assist device there.
That's why I asked. That was interesting. I was like, yeah.
Are you familiar with this? It's WEC, the company WEC. They make a fascial closure device called EFX, endofascial closure. The X is supposed to be it for closure. Yeah, the WEC device is pretty slick. It's you slide it down through the incision. There's a way that you open it on the inside, and then your needle catches the suture. It kind of self-loads the suture, but the part that opens is protective. So the needle can't go past this part that protects. So, I mean, that would, and you don't need another grasper or anything to help you because it kind of...
Do you use that, or is that just something you've seen?
It's available in our OR. I do use it. It's more expensive than the other options. And so...
Now, I oversee the surgical value analysis team, so it's going to be tough to get... If I'm not letting other folks get their expensive toys in, I have to be really thoughtful about which toys I ask for.
Or you just have to negotiate very aggressively,
Yeah, what's the PCI on that one?
Yeah.
That's what are we paying for compared to everybody else? It's amazing how much I've learned. It's been about a year now since I got this job, but my goodness, it is
drinking from the fire hose still, or
I thought I had it bad. We have a new chief operating officer for the entire system, and he just started a little bit ago, and he's great, but the amount of stuff you learn. But no, it's been 12 months. I feel like I'm sort of just now figuring out who everybody is and what I'm doing and all these things and all the ideas that I had. The projects are starting to, it takes a lot. You think OB and GYN and primary care is a lot to learn, and you're like, wait, now it's hospital medicine and behavioral health and ER and lab and all these things that I have to, it's been pretty darn fulfilling for me. It's been something that until I did it, I didn't realize how much I liked it. And I'm starting my MBA in the fall, hopefully. And, I don't want to go back. Not that I don't like what we do here, but I was lucky to get this opportunity and lucky to have such a great boss and team of people who are supporting all the learning that I'm doing. But it's pretty cool. So yeah. So I know a lot of my friends, a lot of our friends, when I told them, they're like, "Oh, sorry." No. It's pretty great. There's a handful who are like, "That sounds amazing."
No, well,
but it takes all kinds.
Yeah, they're, like I said at the start, they're lucky to have you, and I know you well enough to know that you don't give up easily, and so you need someone like that to be a leader and to be able to push through initiatives that make sense, because there's going to be a lot of times where people are telling that you can't do something or that you shouldn't do something, and as long as you have the wherewithal and understand that it is the right thing to do, especially the physicians at your institution are going to need somebody like you to have that physician mindset and get the things done that need to get done. So,
well, nice of you to say. I'm surrounded by a lot of people who share my ideas and who want sort of that's everything, right? We're all paddling the boat in the same direction. It's hard to work for people who want different things than you. It's hard to want to go back to work every day. So that's been the luckiest part of it all, but mostly lucky to have you as a friend, mentor. Again, talk about drinking from the fire hose. What I learned from you, not just about GYN surgery, but all the coding and stuff, and what a gift it was to get to work with you, meet you, and build a friendship with you. So it was a pleasure to have you on. Always something to learn from you, and it's again mostly just a great excuse to catch up with a friend.
Couldn't agree more, Mark. Thanks again for the invite, the opportunity. Congrats on this too, buddy. This is really fantastic.
No, thanks. And again, team. This is Aaron and the guys at BackTable that do all the heavy lifting, and Josh, who is our engineer here on the show today. That it a lot of people working hard just so I get to come here and hang out with my buddies and catch up and talk about what we do every day. So I'm a lucky person in all the ways. So got to try to remember to be grateful on those long days. So, all right, man. Look forward to catching up with you soon. Be well, and tell the rest of your team I said hey.
Will do. You too, Mark.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Overjinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.